Hello.
Hello, doctor.
Yeah. I mean,
Okay. Good evening, everyone. Respected Professor Dr. M.S. Kumar sir, members of IADP and dear doctors, we welcome you back for the another episode of Learn from our Master series organized by IADP. And yes, crossing 15 webinars is definitely an amazing rate so far. And I thank all the doctors who are attending our webinars and other platforms like our Instagram, Facebook, pages, and we are very humbled to see your positive feedbacks. For those who are attending our webinars for the first time today, we will just give a brief introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education is always ensured predictable outcome of dentist of all the disciplines and ability. Our organization is established based on the fact that the industry is complex and require ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide their dental journey. So, without further ado, let's us start our webinar episode in which our topic of discussion is from cavities to craniofacial. Get ready to do the tongue tie release in your practice given by Professor Dr. M.S. Kumar sir. To speak a few words about sir, Professor Dr. M.S. Kumar is honored pediatric dentist with 17 plus years of experience and a pioneer in laser assisted tongue tie release for newborns in India. He is an internationally recognized educator who has trained healthcare professionals across India and abroad in tongue tie assessment, laser dentistry, and pediatric oral care. He is an author of Silent Suffering, The Hidden Impact of Tongue Tie on Health and Well-Being, and has received prestigious honor including FIAPD Fellowship in 2025 and the Nobel Icon Award Excellence in Education in 2025. Dr. Kumar continues to lead advancement in pediatric laser dentistry through clinical excellence, education, and research. Without wasting more time, I would like to invite Professor Dr. M.S. Sharavanakumar sir for the today's discussion. Welcome, sir.
Yeah, thank you for this opportunity, and I thank the association for given an opportunity to share with a lot of friends. I can see a lot of my professor and friends have joined. Thank you for joining. Yes, today we can have some discussion, and I can take a few questions. I think you can see my practice here. I'm still in my practice, and as introduced, it's a pediatric practice, and these are the notebooks where I take notes on tongue tie babies, and we have crossed more than 1,000 babies. So today, the topic, like what we have said, from cavities to craniofacial growth. We all are dentist and pediatric dentist. We are more concerned about the teeth. Um, but always, I after started doing helping a lot of babies and kids who have some difficulty in tongue movements. I always feel tongue as a queen and teeth as a king. So this whole presentation, I am trying to tell you there are different muscles in our face, which will really help in development of craniofacial structures. One of the very important muscle, which is a very strong muscle, and we always call it as a muscle hydrostat. As you know, the trunk of the elephant and octopus, other things which is made up of only muscle. Similarly, tongue is made up of only muscles, and they are being innervated with a lot of cranial nerves. So that is the reason why tongue movement is always connected to brain. If you see, there are a lot of things like Alzheimer and multiple sclerosis. We always tell tongue movements will help to rewire, regenerate brain, and help in the movements. So there's a lot of things to talk about tongue, and as the topic goes, it is really helps in structuring the craniofacial structure. You can see this, our body is made up of a lot of muscles, and tongue is one hydrostat which is connected to bone. All the muscles have two connections, the two ends are connected to the bone. One of the muscle which is connected to the bone on one side, and it is free on the other side. The nature itself tells or signifies that the other side should be free enough to make the basic life functions, like start from suck, reflex, or suck, swallow, breathe, mother feeding, and speech. So all these things, the tongue movement is very important. So here in this presentation, I'm just going to highlight how tongue going to play a very important role in our basic life function, as well as in structuring the craniofacial thing. I'll just go with my slides so that I can show you some pictures. This is the slide which we made it with the chat GPT, and our PGs were giving me this slide, so that this slide tells you how there are a lot of muscles in the craniofacial structure. One important, very strong muscle is the tongue, which if it's restricted, if the tongue is not doing the normal function, there are a lot of effects on the maxilla as well as on the mandible. So you all, whoever is there online, you can just check yourself. If you put your tongue down and start talking, you will not be able to talk as clearly as you can, not able to articulate your tongue and deliver and make a good communication. So this clearly tells that tongue movement is very important and it should not lie down. If it is lying down, and if you swallow your saliva, just today I had three babies here, which were ranges from a newborn to a toddler and an adult also. If they keep the tongue lying down, and if they are not trained, one baby was not having a tongue tie, but still the baby is not trained, or the child is not trained, even the mother is not trained to keep the tongue up and make a proper lingual palatal suction. If it's not been done, there is a chance that maxilla might constrict, and this might lead to the narrow upper airway, which will affect the breathing. And as a chain of thing, it might also affect the sleep. So when the breathing and sleep of a child is affected, definitely their performance in the school is also affected. Their cognitive power, the listening power, and everything is affected, and they might be hyperactive, and there is a chance that they might label him as a autistic child or hyperactive child. So this is how the whole thing goes, and how the craniofacial structure starts from the maxilla and mandible. You know that the mandible follows the growth of the maxilla, as well as the craniofacial synchondroses are there, which if it's not been established in a proper way, there is a issue in the growth of craniofacial structures. And if you see this slide, I just want to show you this slide, how early is the palatal fusion, and the tongue just comes down. And after some time, the tongue starts separating from the floor of the mouth. That is, it will undergo programmed cell death. Okay, it's a programmed cell death, which is going to allow the tongue lingual frenulum to loosen, and then there is programmed cell death, and the tongue starts moving, and the sucking starts inside the womb. So the tongue movement is very important, and this is one of the important reflexes where the baby starts doing it even before the birth. So this shows you the ultrasound of a baby, which when taken as early as 20th week, you can see there is a suck reflex being started. And to this master the skill, they take some time. So if you see some babies who are preterm babies, they would have not much mastered the skill, and they might face a problem with the breastfeeding. So all this you can just take the help of professionals, who we call it as a lactation professionals, and they can check and let us know if there is any issue with the latch and positioning. So this is one thing which we should be always know about this, that the suck reflex starts as early as possible, and if there is tongue positioning is not that good, you might see a baby born with a bubble palate or a high arch palate. So all these things tells that tongue is lying down and it is not moving up on the palate to make a proper architecture of the palate. And if you see this another slide, this slide is to tell you that the muscles starts developing from the similar the neuro box. So the development is from the first branchial arch, and a few parts of the tongue from the second and third. So if you see the nerve supply of the tongue muscles, there are sensory nerve supply, and there are special sensory, and you have motor supply. These are the cranial nerves, which is very much connected with the brain. And hypoglossal nerve is one nerve which is going to help in the tongue movements, the muscle movement. That's why I told you in Alzheimer's disease and multiple sclerosis, there is when you stimulate the tongue movement, there is some kind of regeneration or rewiring in the brain, which is really help their condition. And you would have also know that there is something called motor overflow. Whenever we are concentrating or we are trying to put a basketball on the basket or something, we might tend to open the mouth and put the tongue out. This tells that tongue has a relation with the cognitive and motor function. Similarly, the tongue also is very much connected with the development of speech center and communication center. If tongue is not having much movement, there is a chance that baby might have an articulation problem, which will really delay in communication. And so this picture by Mitchell, which clearly tells the tongue and brain is always connected. And these are the few pictures which we have taken from the textbook, where to show you how the tongue has to rise high up in the palate so that the maxilla develops properly. If tongue is not lying high in the palate, you can see these pictures where the maxilla, the palate gets constricted and it gives a way for the crossbite, posterior crossbite, anterior crossbite, and your tongue space is also restricted. And if there is a tongue tie, it's really going to cause more issues on your upper airway, which is going to affect your breathing as well as your sleep. So these are the things which we will see. And this picture is a very, very ideal, very common heart-shaped tongue tie. If you see this tongue tie, you can see it's in a heart shape, and you can very well see the lot of anatomies here, deep lingual vein, and you can see there is a ductal floor, the duct, submandibular duct opening. And this is the anatomy I was just explaining in the clinical photo, where you have a submandibular duct and the ductal opening, and you have a deep lingual artery and vein. You have a submandibular gland there. You have certain kind of blood vessels, very lingual to the lower anteriors. So this really warns you, if you're having seen any tongue tie, you have to release it with the caution so that you will not affect all the vital structures which is lying very close to the lingual frenulum. As I was talking about tongue, yes, there are other muscles in the orofacial, orbicularis oris. You have all others, zygomatic, major, minor, lot of muscles. All these muscles has to be toned enough. And recently we had a workshop, tongue workshop, which we are talking about the myofunctional exercises. A lot of exercises are there. We have different tools. We have a ice cream stick, we have a straw, we have a balloon, we have a lot of things which to actually tone the muscles. And in my experience, I have seen a few babies, the timing of tongue tie release is very important, whether it's a baby, it is an adolescent, or it's a toddler. They, excuse me, they come, and when we see there is a tongue tie, we should not immediately go and do the release because it's really not going to help you. We have to see the tonicity of the muscle and other structures, whether it's toned to work in synchronize. If these things are not being toned, first we have to do some myofunctional exercises for them, tone the muscles, and then release it so that you get the maximum benefit of the tongue tie release. And as I were explaining, the anatomical structures which are very closely related to the genioglossus muscle, which is a pad muscle, you have a lingual artery there, which is closely lying. So when you are doing it, you have to be very careful that you will not interfere with the blood vessels. Obviously, there will be more bleeding. And if it's a newborn, there is a bleeding mouth, the mother will immediately go for shock, and it will really end up in a lot of other issues. There are a lot of articles to explain you and tell you and how to find whether I have a tongue tie or not. There are the friends who are here. If you want to self-diagnose whether there is a tongue restriction or not, functional assessment can be done. Sarosh Zaki, very good friend of mine, who was given there are different ways grading in finding the anterior tongue movement and a posterior, or you call it as a mid-tongue movement, submucosal where there is no restriction. So there are different ways to find, and normally clinically I ask you all to try to touch the molar tip, not only on the occlusal surface and, and even on the distal or on the buccal surface. If you are able to touch on the distal and buccal surface of all the molars, and your tongue is quite flexible, having a thin elastic lingual frenulum, and your muscle is also toned. There are some adults who come and visit you where there is only a tongue which is going still the premolars, and it will not go beyond the premolar. And that, if you see clinically, and then you can assess, and then you can really help them out, because they are the ones who come to you for the molar root canal treatments. So these are the photographs to show you how to find the maximum tongue opening, and comfortably. You should not do maximum tongue opening like stretching your neck muscles. It's like, ah, that's all. You don't stretch your neck muscles, and you have to measure. There are different tools to measure the maximum tongue opening, that is the maximum interstitial mouth opening. And after that, you can keep your tongue tip at the end spot, tongue spot end, and then try to open maximum. And this, the difference gives you some percentage. And based on this percentage, you can grade whether you have a tongue restriction or not. And there is one more thing called lingual palatal suction, where you try to, it's not only the anterior part, the posterior part also, you should make a suction hole, and then try to open your mouth. And this ratio also gives you the gradients. And you can see the maximum mouth opening, tongue tip to the palate, and then lingual palatal suction. If this gradings are less than 5 or 25%, then it's really very severe. And you can see this photograph to show you how grade 1 looks, grade 2, and this is very severe tongue tie, as we have seen in one photograph. Grade 4 and grade 3. These are the two things where we normally go for the tongue tie release. And you can see grade in lingual palatal suction, the tongue range motion ratio, TRMR means. So this ratio also tells you less than 5 is unable to significant, below the average, below average. These are two grades which we are more concerned. And we can see this highly above average, and severely restricted is less than 24% and less than 5%, and moderately restricted. And always give an option of, if you are very doubtful, give an option of wait and watch, so that you don't directly jump into the procedure and then do, and we will not get expected outcome unless we are very sure that this tongue tie release is going to really help the child. So this is one thing which you have to really uh, uh, you have to understand, that your judgment is very important. So based on this clinical experience, you can do that. And it's always a team effect. It's not only a tongue tie release provider. It is always a speech language pathologist, ENT, occupational therapist, lactation professional. So you going to start a tongue tie release in your practice, you have to need a whole team, synchronize with them, understand what you are expecting, what they have to do. Otherwise, it will be difficult. You tell one and they tell that tongue tie will go off as the child grows, which will never happen, because it is made up of type 1 collagen, which will not stretch during the exercise or massage therapy. So there are different types of fascia, superficial, mid, and deep fascia. The deep fascia is always associated with the lingual frenulum. So this teamwork is always good, as we all are very much used to have a teamwork when we do aesthetics or endodontics or other things. And these are the few. Always I'm grateful to all the people who I have learned and still learning, so that I can always refine the technique and do the best for the babies. So the end benefiter is the baby. So we always keep updated, and a lot of changes 12 years before how I started and what I'm doing now. So you can see this, it's not a new trend that people started cutting a lingual frenulum. The history backs back all over. Even the woodcuts are there, which clearly tells that there is a practice of tongue tie, and it even tells that is as old or even older than circumcision. You can see certain tools are there. Mostly the middle one, the Mickey Mouse grooved tongue connector, is available online, which you can use it to retract the tongue. And this is a cadaver study which is done by Nikki Mills, and she tells that the lingual frenulum is not a discrete structure, it's a dynamic structure. It's not only by just releasing oral mucosa, there is something called fascia, and there is some muscle fibers. So you have to know that there are different types of tongue tie, where there is only a thin flame of tongue tie, and there is also thick a band of tongue tie. And this fascia, which is covering the muscle, is just like your clinch wrap, which is going to cover the muscles or the organs. So once this is how the massage therapy works. When you do that massaging and your physiotherapy, this is what is being released, and you have a very good movement of your hands and the body. I still take my physio because of occupational hazard. And these are the pictures to show you how the tongue tie different types are there. You can see this is given by Lawrence Putlow, type 1, type 2, type 3, type 4 in infants. And similarly, there are different types in the children also. So this type 1 and type 2 is very well seen. Type 3 and type 4 is quite difficult to diagnose, and you have to always do a functional assessment, nothing but you're going to see what are the symptoms they are telling and how anatomically it is seen. So both this goes with a high percentage, then it's always better to go for a release or to wait and watch. What about the lip tie? What is the lip, whether the lip flanging or the lip muscle is very important? Yes, we have done few babies where there is a lip restriction. The lip will never allow the lip to close, so that leads to mouth breathing, and it also leads that baby is not going to allow proper seal on the breast. So there is air ingestion. So because of air ingestion, there is going to be more bloating, and then that leads to digestive issues. And when there is a labial frenulum, which is very severe, the baby is not going to allow brushing. So baby tends to go back, and there is a lot of dental caries associated with the labial frenum. So I have few speech language pathologists who has come, and they told the kids were not able to make few sounds, ooh, ah, ooh. So this is one reason they have come to release the upper lingual labial frenum. And these are the other photographs is there on the textbook and in your media, where you can see that tongue restriction causes different. You might see clefting at the tongue tip. You might see the lower anteriors being a diastema there. You might see the yes, you might see the lower anteriors is tilted lingually because of the tongue lingual frenulum pull. So even though it's a small tissue, there is a lot of issues with this because it is having a fascia connection from ear to your hip bone. So you have to understand this. With the due respect to all the mothers who have lot of issues while breastfeeding, so it's not only a tongue tie which is going to cause breastfeeding. All breastfeeding problem is not only because of tongue tie. Tongue tie also might cause breastfeeding issue. So this is one thing very important. So when there's a tongue tie, you can't immediately jump in and tell your baby has a tongue tie and your baby will have speech issue, your baby will have digestion problem, your baby will not breathe properly, your baby will not sleep properly, and this definitely going to have a psychological impact on the mother, and the mother milk production again it goes down. So you have to be very careful as a pediatric dentist. You have to sit listen to them what they are telling and then guide them accordingly. These are the few clinical cases to show you. This is the middle one is after release, and these are the few other photographs to show you there are different types of tongue tie restriction which is going to pull the submandibular duct up high. And this is again a clinical photo to show you how there is a deep, very clefting alveolus because of very severe labial frenulum and as well as the lingual frenulum. Earlier, 10 years before, we all had a understanding that whenever there is a tongue tie, there is a lip tie. And I myself have done few babies where there is tongue tie and lip tie together. But now I examine in such a way, if there is a tongue tie, if it is going to affect much, then I'll do only tongue tie. If there's only a lip tie which is affecting much, then we do only a lip tie. So this is after release photographs to show you how it looks. It is the healing tissue. It is not SCHAR, it is just healing tissue. It takes some time for the tissue color and texture to come to normal, as we all know that the oral tissues heals little faster than the other parts of the body, and give instructions to them pre exercise and post exercise. You have to give, they should try feeding. Yes, tongue tie also has a big role in speech. The articulation, as I told you, will affect. Tongue movement actually stimulate the brain development. That's why we tell to do as early as possible, so that your brain growth also related to the tongue movements. We have seen a lot of kids who was not even uttered a word of amma, appa in the earlier days. They were just quiet. They're not communicating properly. So the tongue tie restriction has a very big role in speech language center in the brain. And this is one child, very severe tongue tie, and is a child we have to deal specially. So we have done under general anesthesia and using lasers under general anesthesia. There is no contraindication until and unless you tell the anesthetist that you're going to use a contra laser in general anesthesia, and there is no contraindication to use laser in nitrous oxide also. And this is one picture I've taken from my friend with permission, that you should not do as deep as this with the laser. It's something which we should not do. This photograph will show to you which how we should not do. So severe injury for the floor of the mouth is not advisable. Yes. Always first to do no harm is very important. And there are some tongue tie which might be, recently I saw many people are using, it's a mid mid tongue tie restriction, and I always use the older terms like posterior tongue tie, because I still believe there is an anterior portion and there is a posterior portion. We have to release both. And there are many people who understand and they release only the posterior portion, which they don't address the anterior portion. So that is one important thing. And these are a few things which I thought I will share with you. Since we are a pediatric dentist, we deal with a lot of newborns for the natal teeth and for infant oral health care. When we hold the brain, we should be very conscious. When we hold the head, we should be very conscious. You have a pulsating frontanals, so unnecessarily don't give too much pressure when you're holding the baby. And you can see there are the newborn cyst. They even come for the checkup for the newborn cyst, whether this is a candidiasis or any other issue. You can tell them it is self-limiting and it get done as the time goes. When examining this kind of babies, you should know that holding them very not too much of pressure should be given, because you have a posterior frontal and anterior frontanals. The posterior closes early 2 to 3 months, and the anterior closes by 1 to 1.5 years. This is a picture to show you how the posterior frontanals closes early, and then the I have many times I've got my hands here. You have a pulsation here on the anterior frontal. So this is just to share that we all know this, but I thought just I'll share you. There are n number of articles which clearly tells that ankylosing tongue-tie division on speech articulation, it's very important. I have seen a lot of things, changes in this field of dentistry, and it is a multidisciplinary. Now, a lot of speech language pathologists trying to understand that restricted tongue movements, it's having an effect on the speech and communication and articulation and skeletal malocclusion. There is a lot of studies which tells that when the tongue is lying low, there is a maxillary constriction, and this might lead to the sometimes it tends to develop for the class C malocclusion. And when you see the lip ties are one thing. I just showed you a picture by Lawrence Kotlow, which when you reflect the lip, it has to close the upper nostrils. If it's there is a pull in the middle, very deep. And I always tell you, if it is a class 4 lip tie, it's always you should think of releasing. But still I see a lot of class 4 where the teeth is normal, there is no much spacing in the anterior. Then I tell them we'll wait whether the permanent comes same or there's too much spacing. So these are the few things which is very controversial. We have to wait and watch. This is again a photograph picture slide to show you how tongue tie. There are different types of tongue tie, and what is the percentage. It runs in the family. It is in the mutation of gene in TBX22. And whenever you see a baby with a tongue tie, you can always trace it out with the mother or a father or their grandparents. You might tell, they might tell, they are telling a lot of histories that this my father's father had some issue on speech. You might get some kind of how sleep apnea. Definitely, we are in the world where we are addressing more on sleep. It's very important. And tongue movement, I have given shared my knowledge in a lot of sleep conferences, ENT conferences, pediatrician conferences, and told how the tongue movement is very important, how it's going to have a good palatal suction. So these are the articles and pictures to show you how tongue movement and circadian rhythm is affected. And when the tongue is being pressed against the palate, there is a hypothesis where the pineal gland is being stimulated to secrete melatonin, which helps in sleep. This is one thing. And there is one more thing. When you put your tongue out and then you breathe, there is a This helps to low down your stress. Cortisol secretion is there, and one more thing is you try to do moving different hormones or different enzymes in your body like dopamine, oxytocin, serotonin, melatonin, feel good factors are being increased. These are the red flags to show you how normal palate and the narrow palate is definitely going to affect, and your adenoids and tonsils, if it is been associated with that of your tongue tie, it's still going to worsen. And this is a picture to show you how the tongue lies high in the palate, and if it is a restricted tongue, you might see that your uh, your tongue is lying down and it is more posterior. It's more posterior and it's going to reduce the upper airway. You can suggest there is a link between Christine Gullimot is one of the very much pioneer in telling that tongue tie is a phenotype, which is going to be very evident in obstructive sleep apnea. And there is a small video which shows that how the tongue restriction, if there is you get a snoring, this is there on the online. You can see that NYC sleep well. And if you do a tongue tie release, and this is really going to help your tongue to position high in the palate, and this is going to reduce and increase the space posterior your upper airway system. So this is just to show you how important is the tongue movement and how it's really going to help you in breathing. There are a lot of studies which tells that ankyloglossia is associated with obstructive sleep apnea. You have systematic review meta-analysis which clearly tells that restricted tongue movements is going to affect uh, the sleep, and the position, the posture also is affected. And there are a lot of ways how you can treat your constricted maxilla. You can give different types of maxillary expansion, slow, rapid maxillary expansion. You have other doom, and you have surgical marpe, sarpe. A lot of things are there. I'm not going deep into that. There are different tools to do a tongue tie release. I still feel comfortable with the laser. Once you've been trained with the laser properly, that really helps you to do quickly and have a clear field. When you touch with the scissor, you bleed and you will not see a fascia release there. That can be done very well with the laser, and you know how to do it as quick as possible. I used to, and these are the words from the stalwarts in pediatric and in tongue tie release, Lawrence Kotlow, Bobby Gary. They very clearly tell that quick snip is not sufficient enough, which has been practiced still by many people. But still, I don't tell you should not do it. That really gives some benefits for the kids, but not much as that you do a proper functional release. So this is again Bobby Harry's website, and we know the guideline from AAPD, which clearly tells laser as a beneficial instrument for providing soft tissue procedure for infant children and those with healthcare needs. And the guideline in 2020 tells that laser use for the frenal release is one lot of advantages are there. Frenulum in pediatric dentistry management. So the tool also plays a very important role. Um, so we come from managing only the cavities, doing a lot of pulpectomy, stainless steel crown, and a lot of things. I still love doing that, and I still see a lot of friends doing that in a very nice way, doing a lot of zirconia crowns and other things. but still there is something else called the tongue, which is really affecting the craniofacial structures. Yes, thank you very much. Thanks for this wonderful listening. And yeah, when it's 8:30, I was really thinking how I'm going to make it up. And today I somehow tried to just cancel few appointments, but still it was not possible. So still I'm in a practice. Thanks for your time. Thank you very much. Yes, quickly, anything else, Jonah? Are you there?
Yes, doctor.
Yes. Thank you. Thank you much.
Okay, doctor.
Thank you so much, sir, for sharing your knowledge and expertise when it comes towards managing tongue tie cases and performing tongue tie release. Surely, many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. Thank you all doctors for the patient listening and your participation for this webinar. And I hope all of you will depart this section with positive, confident manner. Once again, thank you so much, sir. It was a wonderful and informative section, and we really appreciate your valuable time given to us for this series episode. Please do check out and follow Sir's Instagram page where you can appreciate his clinical cases. And to know more about our upcoming webinars and workshop, please do check out our website, which is iadp.org, or you can follow our Instagram and Facebook pages as well. And if you have missed out our previous webinar, do check out the YouTube channels as well, as we really appreciate if you could subscribe as well. So thank you all and have a great day.
Thank you. Thank you much.
Thank you.
Anyone needs any help or anything quickly or? Can we use electrocautery to remove tongue tie? Yes, you can use electrocautery, you can use BP blade, you can use scissor, but it all depends where, what, how it is, how there are a lot of latest things which is available. You can use even coagulation with the ice. So it all depends. Electrocautery is going to be more powerful. Suture required in electrocautery. Electrocautery and laser is going to occlude your blood vessels. So whenever it's a big wound, then you can suture. Otherwise, you can just leave it up. How to assess speech dysfunction due to tongue tie? What specific letters? This actually I refer to a speech language pathologist. I'll tell her I feel this guy needs assessment by you, and then tell me. Scalpel, yes, I told you there is a bleeding there, and the control over that while doing, see, it's very the smaller depth when you cut it with the laser, very minimally invasive. You can just see the cell death or cell cut is very less when you do it with the laser. Tongue tie and TMD, yes, there is a lot of relation with the TMD. You have a popping sound. You have a lot of articulation problems, dislocation when tongue tie is there. Yes, there is a lot of association. Thanks for you all. Thanks for joining. Thank you, madam. Thank you, sir. Many people of my friends are joined. I am really thankful for you and for your best wishes and for the support. You can hold artery forceps, frenum, suture. See, earlier what we do, no, you take artery forceps and cut up and down and remove the whole tissue. That is not been practiced. I am not practicing that. And there is a brain formation. How does tongue tie affect the brain formation? You can just see there is a lot of articles which clearly tells finite element assessment in tongue movement and brain development. You have a very good article is there published there, and thanks for this compliments. I really appreciate you. If as the moderator told, you can connect with an Insta. That is one thing, because I have taken time to discuss with you all. Thank you very much. Have a good day. Thank you. Thank you all. Thank you all. Thank you very much.
Good night, doctor.
Thank you. Thank you, madam. Where it is to stop.